for Data Collection Management, Reporting, and Suicide Fatality Review. Before we get started, I'd like to...
Hi, everybody. I'm Susan Herzfeld from Public Health Dayton-Montgomery County. Welcome to Data Collection Management and Reporting.
And I'm Lucy Rucker. I'm from Zanesville-Muskingum County Health Department. So today we are going to talk about identifying suicide-related metrics and potential data sources, describing two different approaches to data management, and explain required and optional elements of annual reporting to ODH.
A little bit about us and our counties. I'm from Montgomery County. We have Dayton. We have about 500,000 people, 537,000 folks. Last year we had 101 deaths by suicide, a bit higher numbers. Our SFR began in 2021. We had an OFR for a few years, and then after the legislation expanded to include this. We have a standalone committee, quite a high number of deaths in both of them, so each meets separately. And we meet quarterly in our county. All of the work is done by me. I'm the behavioral health epidemiologist. I do the facilitation, the data, the coordination, and I work with our local community coalitions for prevention work as well. I'm in the southeastern part of the state in Muskingum County. We're considered Appalachian. We have a little over 86,000 residents. I'm dealing with much smaller numbers than Susan. So we had 14 suicides in 2023, and we had 6 so far in the first half of 2024 rather. We have a hybrid committee that began in 2018, and we meet quarterly. But full disclosure on that, our committee was really just doing aggregate data until very recently, and I've been on this team for about a year. So I'm like from the school of, you have to begin somewhere, so don't be scared and jump right in there. So we're like educating our community on the law changes and everything. So even though the committee existed, they weren't really doing case reviews until very recently. So I'm the epidemiologist for the Community Engagement and Performance Management Department, which includes our harm reduction team. So there's a couple different ways that we collect data for fatality review. The first is case review. So this is going to be an in-depth discussion of an individual case. This is going to be information that maybe you can't get for every case, but when you look in depth with one and you invite your partners to a table, you can get more information. We use this to look in depth at one specific case and develop recommendations for our community to prevent future deaths. So some of the information that we look for is personal history, the individual's medical history, especially any chronic or terminal illness, any recent changes in prognosis. Also mental health history, were there screenings? What did those look like? Was there any follow-up? What was the transition of care? What was their trajectory in that circumstance? An individual social support is really important, both for any risk factors as well as protective factors. How can we wrap family members in preventing these future deaths? We also look at financial status. This is going to be harder to get on a bunch of cases, but if you look at one more in depth, you might be able to get some information on their housing, their employment struggles. These can kind of give you some of those risk factors for a suicide death. And finally, substance use history and recovery. My background is in overdose. I came from overdose prevention. So I'm always looking at that as well. And we do see some of those themes in our suicides in Montgomery County. There are also additional items for suicide risk if you're coming from an overdose or from another background. Recent changes or sources of stress, so specifically significant and sudden legal problems, relationship changes or conflicts, health changes, economic struggles. Exposure to suicide, we all know that's a risk. That's something you might get from an in-depth look at a case. Access to lethal means, prior attempts, a history of self-harm, recent signs of suicidal thought, but also those protective factors are important as well. Those can provide us ways that we can look at supporting folks, providing additional prevention measures through the people that are around them and the resources and connections that they do have. We're both EPIs, so we also look at kind of the broader aggregate data. These are going to be things that you can't collect that aren't as specific to one case that you can collect more routinely. So it's going to be less data, but you might be able to collect it more frequently. And the goal here is to identify broader trends to inform your prevention efforts. So those are going to be things like basic demographic information, age, sex, and race. Education and occupation are also on death certificates. They're reported by the family, so they might not be as concrete, but they might be helpful in telling you something about that person's history and their life. You can also often get circumstances, method, toxicology, location, whether was there a note from the coroner's report. And any noted recent stressors. Things that we've seen in Montgomery County include recent legal changes or relationship conflicts or financial changes. Also, they might note some suicide risk factors, known physical or mental health conditions, prior attempts, thoughts or self-harm, or exposure to suicide. These might be noted, they may not, but if your coroner will routinely record that, it's something you might be able to include in your trends. Other things that we have access to that other places may not include medical, criminal justice records, anything where an individual from an agency will send you kind of routine records for all of your cases, rather than kind of looking at each individually.
Okay, so places where we might find some of these data sources, the coroner's office is a big one, so you can get hopefully coroner's reports, toxicology reports, vital statistics where we can get our death certificates, the criminal justice records. I use a few different clerk of courts. We have a county and a city in my county. Hospital systems, mental health boards, first responders such as fire and EMS records, your ORS reporting, so your Ohio Automated Prescription Reporting System. So a doctor can look those up for you. So you should have a doctor on your committee. Children's services, post-vention support systems, next of kin interviews or psychological autopsies. And then we just scour what we can, such as like obituaries and maybe social media posts too. So there's definitely challenges with getting the data that we need. So partners might be unwilling to share, they might be unable to share. You might not get the data in a format that you can easily use. Don't know where to start, don't know where to find the data that you need. Maybe you don't have a partnership with a certain sector that you're lacking in your committee, and maybe just lack of staff time to and knowledge to organize the data. Susan does it all, and I do a little bit of everything. So this is not my only job at the health department. I do a lot of other things as well. So some strategies to overcome these. Definitely educating your committee members. That's a big one. We're still working on that in our committee for sure. The confidentiality agreements, which would be like per member, and the non-disclosure agreements, which are per agency. Building trust, just building those relationships with your community partners. Reinforcing the fact that it's a confidential meeting. Building new community partners, so maybe, again, you've identified a gap, so you need to get some other folks on your committee. And then eventually, hopefully, you can get your SFR funded so that somebody has time dedicated to just do this. We are not a funded SFR, OFR at my place. Okay, so I do not use anything fancy. As I mentioned, I don't deal with huge numbers of deaths in my county, so I just mostly use Excel. So we have a locked Teams channel that I have access to that other people cannot get into. I literally have just I organize it by year and then by quarter, since we meet quarterly, and then I have a separate folder for my annual reporting. So I just have an Excel spreadsheet that I have several different tabs on, and if you go across the top of it, you'll see that I just basically enter the information that's on the death certificate for starters, and then it gets more detailed from there, and I have tabs for different things. And I can just make my graphs right from my Excel sheets for any presentations that I need to do. There's an example of my little subfolder, so the different types of documents that I acquire, I sort them into folders. And then I have a master list that's like kind of our master database list. And so on that, it just has more minimal information, and I just have a tab for each year. So if I need to look back at something, I can pull it out and see which folder I need to go into. So for aggregate data, as I said, until recently, that's all our committee was doing. So we used to do a full PowerPoint presentation of just aggregate data quarterly, but now we've moved on to doing case reviews. Most of our time is dedicated to the case reviews during our committee meetings. So I send out one-pagers with our quarterly synopsis of aggregate data on it. And then the types of things that we used to put in our old style is now what I do like in our annual report, basically. So I like to make comparisons to like the state of Ohio so that we can see how our county compares to the state of Ohio, for example. So I would have lots of different graphs like this in our annual report. And since I have a hybrid committee at my health department, I do try to color code things. Just I feel like it organizes stuff better for everybody's brains because we'll talk about both things in one meeting, right? So we might start with overdoses and then move on to suicide fatalities. So I just keep it color coded. So benefits of my method, it's pretty simple. Everybody probably has access to Excel and has somebody that can do this for you. I can make my graphs and spreadsheets, or write in my spreadsheets. I don't need to export anything, do anything fancy with it. But obviously, if you're in a larger jurisdiction that has a lot of deaths that you're dealing with, it's going to be pretty hard for you to keep up with this potentially.
So I know a lot of people have thoughts about access. I tried for a long time to keep up with my deaths in Excel. I started with overdose. We had 566 deaths in 2017. I'm up to about 3,000 overdoses that I'm keeping up with. Expanded to suicides, about 400 of those. When I try to do this in Excel, I mess things up. I go to recode things and I kind of mess with the original data. I go to make a table and I like access because I can import a couple of different resources. I have my ODH mortality data. I also get a spreadsheet from our coroner's office. I can upload those into Access, into my database, and then I can abstract additional information from the coroner's narrative, from obituaries, from criminal justice, and then I can export those in a formatted way to both Excel and to Tableau, where I can create data visualizations and I can analyze and create dashboards and kind of have more frequent updates for my committees. This is what my data collection form looks like. There are a couple things here that I like to collect that I added through a couple of years of reviewing cases and finding some trends. I had a lot of this information to begin with. I added apparent planning, so was there a note, a call, a text, or a call to law enforcement specifically? I added, was there an assault involved or a murder? Were others present or police present? These are some trends that I think are starting to pop up in some of our cases that I've added, and things that I can kind of abstract from reading the case reviews. I also have information on health, physical and mental illness, mental health treatment, substance use treatment, some other physical and mental health indicators, suicide risk. The things I mentioned before, a couple of the trends I've also added were imminent legal trouble, a terminal illness, or a breakup or conflict with a partner. Things that we see frequently in some of our reviews that I added might be helpful to collect from the beginning. Finally, criminal justice history and talk screen. So with all of these, I can kind of import cases with the spreadsheets that I'm given, abstract additional information, and then kind of export it to both Tableau and Excel to do some data analysis. So here's one of my Tableau files. So this shows the increase in deaths between 2020 and 2023. We had a pretty significant increase in Montgomery County. And this is something that I can catch pretty quickly when I'm kind of organizing information and formatting it in this way. Here's another one of our, this isn't public, right? This isn't a public dashboard. This is for internal use. So by entering the data into Access and exporting it here, I was able to see this kind of increase in our Black men who passed away with an overdose a little bit more quickly than I might have otherwise. And I don't have to come in and do it by hand each time. Here's another one. So you can see an increase in ligature and hanging and poisoning in the last couple of years and a decrease in the percent of deaths that involved firearm. And I also have information on the talk screens here. So rather than having to kind of create a new report each time, I can kind of go to each of my local coalitions and provide a report and update based on the information that I'm pulling from this. So with larger numbers, this has been pretty helpful for me. Some of the benefits to this are I can import and export formatted information. I don't have to receive a death certificate and kind of type everything up again. This allows consistent data collection, so I can make sure that I'm abstracting the same information each time. I also preserve the underlying data when I analyze it. It's all in my database. I can export and analyze it there. There are challenges. It's a steep learning curve. I kind of inherited an Access database in a prior position and recreated it here. It is time intensive to create, but once it's created, things go a lot more quickly. So again, I probably wouldn't do this with a smaller county, but with our numbers of deaths in Montgomery County, it's been helpful for me. So there's a couple of different ways that we can do reporting for suicide fatality review. The first is trends in total suicides. We report these quite as frequently as possible. In Montgomery County, we get daily reports, so we're able to kind of see an increase in in suicides. We also include suspected deaths in Montgomery County. I know that wouldn't be possible everywhere. When deaths are finalized, we can do quarterly and monthly reports. I always provide an aggregate data report to my committee as context before they start their case review. I also have a couple of other groups that I provide to, some prevention groups, the Prevention Coalition, our Zero Suicide Committee. And we also can do final annual reports and data requests as they come in. Some things to think about with reporting. I would provide one type of report and presentation to epidemiologists than I do for some of our local coalitions. They're not data people, they just want to know what are the trends you're seeing and how can we use that to help prevent future deaths. So I would give them something like this. It's got a clear message, right? So we saw an increase in the percent of deaths that had poisoning as folks got older in these particular years. It informs prevention. You can do something with this, right? You can look at lock boxes for medication. You can do counseling at the point of the pharmacy or the physician's office. And I would also just remind folks that language matters, especially when you're speaking with with people with lived experience in some of your community coalitions. I tend to think of things very clinically when I'm doing data. That's kind of how I take care of myself in doing that, but humanizing it a bit more when you're talking to folks in the community who are doing this work is important to kind of establish credibility. A couple other examples of how I've used data to tell a story. In Montgomery County, we used to have around 80 deaths per year. It was pretty consistent. In 2022 and 2023, we saw a pretty significant increase. I think our final in 23 ended up around 100. So I like to show this information to tell a story. And so when I was looking into that increase in deaths, I saw it in a couple of areas. The first was folks under 25 increased as a percent of our deaths from around 11% to close to 20%. And the other was white women who increased. The fonts changed a bit here, the font sizes, from when they were on my screen. But they increased from around 15% to 24% in that 1 year. So if I looked at that 1 year, the entire increase was among those two groups. So that's something that I was able to share with our local coalitions to see the work that they could do to prevent these deaths. We're fortunate in my county that folks really are hungry for this data and like to have kind of quick, clear messaging of what the trends we're seeing and what kind of prevention efforts they can have.
So in our county, we've started using Clear Impact software, which ODH gave license to all local health departments, to my knowledge, so people should have access to this if they're interested. So we do have dashboards that we use internally, but then I also have a harm reduction dashboard that's on the website. So it's just very simple. It's not as fancy as Tableau, but it does make some nice little graphs that I keep up with monthly, quarterly, yearly, depending on the metric. So here's a screen grab from what that looks like on our harm reduction dashboard. And then you can do some disaggregation. You can compare, males, females, different age groups. And then down at the bottom, the story behind the curve, you can make it a bit fancier and put lots of narrative in there or whatever that you like, really.
Yeah, so as EPIs, we're used to providing reports and trends on aggregate data. Reporting out of suicide fatality review is a bit trickier, right? You can't report percentages. But after a number of meetings, you can come up with some themes that are pretty consistent so that when you're providing other data, you can kind of use these to tell the story behind some of those numbers. Some of the themes that we found in our county, a lot of prior trauma that folks may have not been familiar with for the individual, but kind of come out after their death. Mental illness in a lot of cases, although not all. A painful or terminal physical illness, especially if somebody had a recent change in their prognosis shortly before their death. Sudden significant legal problems, often happening in the hours to days before their death. Or stressors, including relationship, caregiving, or financial difficulties. These are all themes that we see pretty consistently, and I would say most of our cases have at least one of these. There are a few that don't, but most of them fall into one of these little buckets. And you can use these themes, as I said, to emphasize some of your aggregate findings. So for instance, I showed a screen earlier. I didn't really kind of linger on it. Half of our folks in Montgomery County had either ethanol or THC in their system when they passed away of a suicide. Wasn't a poisoning, didn't necessarily cause it, but may have contributed to some of their mental state when they passed away. What that doesn't tell you is something that we've come across in our case review, which is that often an individual that we look at who had a relationship conflict in the hours to day before they passed away also had one of these substances present. So that kind of combination there can tell you a little bit about what you can do for prevention in terms of domestic violence outreach or relationship counseling, wraparound services with family members, things like this, looking out for means reduction. It tells a story a bit more behind some of that substance use that might be present. So I like the richness that you can get from some of these cases. Not all cases will have that much information, but when you do, it can be really powerful to kind of be able to tell that story for the individual. We also try to always develop recommendations for each case. Sometimes, especially when we were starting out, these were all process recommendations. It was, here's who we need to have at the table. How can we invite them? How can we get this additional information? If one day we can start doing next of kin interviews, what do we want to ask that we're not getting now? It took us 2 years. We're finally getting some interviews for our next meeting. And once you have those recommendations, it's really helpful to track the progress and report back to your Suicide Fatality Review Committee so they can see that the work that they're doing is having an impact. Some of the recommendations that we've had that came out of specific reviews: increasing social opportunities for older individuals, especially folks with a chronic or terminal illness. So working through the Area Agency on Aging, working through medical providers to kind of provide some of that outreach specifically for older folks in the community. Prevention outreach to gun shops and ranges. That can include QPR training, post-vention services after a suicide death in the community, and some of the communities with some of these gun owners. Working with elderly individuals to plan disposition of weapons following death or move to care. So it's hard to talk to folks about how are you going to keep yourself safe with your firearm in your home. But if you kind of structure that conversation around, well, one day you might pass away or one day you might move to care. How are you going to take care of that firearm? How are you going to make sure it doesn't fall into the hands of somebody that you may not want to have it? That can kind of open up that discussion of how do we maintain safety with that firearm. Finally, education about the side effects of some medications, both for providers and for family members and patients. Some steroids can have a psychotic side effect. Some benzos can have cognitive side effects that might impact people in ways that we don't know. We've seen a couple cases impacted by these as well.
Okay, and then this was touched on a bit in the last session, but annual reporting. So this is now in your SFR manual as well, but there's a website off of ODH's website that talks about this. So it tells you what information is required and what is optional. So it'll take you through exactly what you need to put in this. You'll need to have your total deaths that occurred, the total number of deaths that were reviewed, number of deaths not reviewed, and then demographic information for the cases that were reviewed. Optional information includes toxicology findings, factors that were found to probably contribute to the death, health factors, and other history as determined by the committee. So there's basically a little mini red cap form that you'll fill out, and you'll attach your full annual report to that. It's pretty simple, and this is due by April 1st of each year. So that's the end of our presentation. We're ready for questions.